This is TTT Live. I am DK Rostar. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Chalk City 91.1 FM, and on Facebook at TTT Live Online. We go now to the Manager Corporate Communications at the Ministry of Health, Candice Alcantara.
Good morning. We are pleased to have you back with us today for the virtual media conference hosted by the Ministry of Health as we seek to keep you informed of the national COVID-19 response. Here to present the latest updates on COVID-19 are Dr. Roshan Parashram, Chief Medical Officer, Dr. Avery Hines, Technical Director of the Epidemiology Division, and Dr. Sana Mohammed, Consultant Pulmonologist with the Eric Williams Medical Sciences Complex. I am Candice Alcantara, Manager Corporate Communication at the Ministry of Health, your moderator this morning, and we go to Dr. Parashram, who will deliver today's clinical update.
Hi, good morning. Thank you, Ms. Alcantara. Morning to Dr. Hines and Dr. Mohammed, members of the media, members of the viewing and listening public. So we'll begin with the clinical update for January 26, 2021, giving you the total number of tests at the public and private sectors, 82,180. The number of new positives recorded over the last 24-hour period, 6. The total positives in country so far from 12 March to present, 7,496. Total recovered patients now stand at 7,058. Active cases are 304. The number of deaths remain at 134, and the total hospital population stands at 39. Those that step down are 8. At our quarantine sites, we have 407, and in home isolation, 253. With respect to our positive patients in hospital, we have 27 at the Couva Hospital and Multi-Training Facility. There's 3 persons in ICU, 11 at Cora, and 1 at Scarborough General Hospital in Signal Hill. Our step-down facilities have 6 persons. Claxton Bay Correctional Facility has 2, and in Tobago there are 4 persons. With regards to our step-down quarantine facilities, at the Chancellor Hotel there are 13 persons, Cascadia 42, Regent Star 27, Paria Suite 76, UTT Valsine Campus 86 persons, UWI Canada Hall 8, UWI Freedom Hall 26, Cara Suites 9, Cara Suites 5, Cape Park Hotel 97, at the Napa 15 persons, at the Tradewind Hotel 21, and at Southern Medical Facility there are 2 persons. With regards to, I just wanted to take the opportunity to remind persons of the update that was sent out from Pfizer-BioNTech COVID-19 related to its vaccine of 8th of January 2021. There seems to be a little disquiet in the population with regards to that particular vaccine and how it is to be used in Trinidad and other parts of the world. So the Strategic Advisory Group of Experts on Immunization, the SAGE group, would have met and published on the 8th of January 2021, which is a WHO subcommittee, actually advising the following as it relates to persons with allergies. That those persons with allergies, people with a history of severe allergic reactions to any component of this particular vaccine, should not take it. What we have seen over the last couple of weeks is that some research has been completed to this end. The Pfizer vaccine in one particular instance has been given to over 4 million persons. The incidence of this particular side effect, severe allergic reactions, out of over 4 million people, we got 11 such incidents occurring. Out of the 11 cases, 7 were in known persons who already had severe allergic reactions to other things, for example, seafood, medication, or some other form of food. So in Trinidad and Tobago, in our phase 1, we are not actually going to give it to persons who have a history of severe allergic reactions, trying to get that number as low as possible in terms of complications to the vaccine. So by way of the second category, pregnancy and breastfeeding women, again, Trinidad and Tobago is aligned to WHO at this point, and they are advising that it should not be given to pregnant patients at this point in time. With regards to children under the age of 16, again, we are not using in that age group in the first instance. people with known medical conditions, for example, hypertension, diabetes, asthma, pulmonary disease, liver or kidney disease, as well as chronic infections that are stable and well controlled, it is recommended that those persons have it. And again, and people with those conditions are part of the phase 1 vaccination strategy in Trinidad and Tobago. People who have had COVID-19 previously, and again, vaccines should be offered. What WHO is advising at this point is that based on, of course, supply of the vaccine, individuals may wish to defer their own COVID-19 vaccinations for up to 6 months after the initial infection. And this is based on the recommendation again from SAGE. So they may not be in the phase 1 part of Trinidad and Tobago vaccination drive. Again, the dosage, and we will be sticking to the manufacturer's specification with regards to dosage if we are using this vaccine, which is 2 vaccines given 21 to 28 days apart to give the best efficacy, and that's where the data lies. So we'll go straight to Dr. Hines and then back to Dr. Mohammed after that. So Dr. Hines will now go into the epidemiological update for this morning.
Okay, thank you, CMO. Good morning to Ms. Alcantara. Good morning to Dr. Mohammed. Good morning to the members of the media and the viewing and listening public. Today we're going to update the epidemiologic situation using the following slides. May we have the first? So the data that we're presenting is at the 4 p.m. update for January 26th, yesterday. Looking at the epidemiologic curve, that epidemic curve demonstrates 2 things. It demonstrates the historic information, the historic data, now frame shifted a bit. So we're now looking at the left-hand end. We're seeing basically from the start of August, and we're seeing that upward trend at that point in time that then continued slowly downwards with a couple peaks relating to various clusters in controlled settings, which were then managed. All of the gray colored bars are the bars that represent days in the year 2020. So basically from the end of July through to December 2020, those bars are in gray. The new data, the data for January 2021, is currently at the right-hand end of the screen, and that is those green bars at the end representing the data from January 1st to date. The things to note there really are that the average number of cases, that rolling averaged black dotted line, did demonstrate a bit of an upward trend, an upward curve in the early part of January that seems now to be trending downwards again. If you look at the heights of the bars, height of the green bars compared to the ones that are gray right next to it, so the numbers of cases per day in January as opposed to December, you do see that we have seen slightly more cases in January, especially in the early part. Those bars are taller than in the corresponding end of December. As we said, we do suspect that that may be related to any enhanced or increased tendency for individuals to come together over the festive season, although the data at this point suggests that that may have been a very limited occurrence. And again, we'd like to encourage the population to stick to limiting those gatherings as much as possible. Anything that we do by way of gathering does show up in changes, in inflections and reflections in the numbers of cases on a daily basis. So if we keep as we're going, if we continue to adhere to all the public health guidelines, we're hoping to keep these bars as short as possible and that black dotted line as flat as possible or trending downwards if that can be accomplished. Moving on to the next slide, we look at the demographics. Now, this demographic pyramid, what we call a population pyramid or a case pyramid in this case, shows men in blue on the left, women in pink on the right, and the individual bars corresponded to the various age groups. A little bit hard to see in this slide, but 5-year age groups, beginning with the under 1, then 1 to 4, 5 to 9, etc. If you look at the bottom few bars, the first, second, third, fourth, fifth, even sixth bars, those corresponded to individuals under 19 years of age. And the reason I'm emphasizing this at this point in time is we are reiterating that the public health measures that we've been taking have been to some extent sparing that under 19 age group, that pediatric population, that school-aged population that we have taken out of public circulation So we're going to be monitoring for changes in the proportion of total cases that the under 19s make up as we go forward, as we increase levels of movement among that age group, as we begin to have more face-to-face classes. At present, that age group, the under 19s, constitutes about 9.8% of the total COVID cases, whereas that age group constitutes about 28% of the general population. So there you see that relative sparing, that relative constriction. Looking at the 25 to 49 age group, that's basically the longest bars in the middle of that pyramid. We see that that's basically where the majority of our cases lie. At this point, 55% of all the cases that have been diagnosed have fallen within that age group, and that corresponds to the movement of the adult working population interacting with each other, and therefore at higher risk of coming into contact with infected individuals. We do see that there is what we call a slight male preponderance. At this point, 53.7, nearly 54% of all the cases that have been diagnosed have been among men, 46% among women, and that proportion we basically would still call just about 50-50. Slight male preponderance, but 50-50. If we move, however, to the deaths, we see that distribution is in fact quite different. So 3/4 of the deaths were among men, 73.9, 74%, almost 3/4, and 2/3 just about in the age group above 60. So the other thing that we keep reiterating is that people with pre-existing conditions had higher risks of death regardless of their age. And this, again, is something that we are emphasizing in the context of encouraging those with pre-existing conditions to get the vaccine, because the vaccination then primes your immune system in such a way that you reduce your risk of severe disease and you reduce your risk of fatal outcomes. That has been the outcome of all the studies, the phase 3 and the ongoing studies of the vaccination. To date, risks of severe disease, risks of hospitalization, risks of death have come down in the age groups that have generally been at higher risk among the populations that are more vulnerable once that vaccination has been given out to a sufficient proportion of the population. So we want to encourage our populations that know that they're in the vulnerable groups to come forward and to be vaccinated so that we can reduce our risks in those populations as well. Moving on to the last slide, the geographic distribution remains largely as we have seen with the, for want of a better or less vague term, with the east-west corridor from St. George Central into St. George East, more St. George East, and parts of St. Andrew, St. David, showing the largest number of cases in various communities. We see a couple darker spots in the County Caroni and actually in County Victoria. But those numbers, if we actually look at the key, don't represent very large numbers in any community. The highest number represented there is actually 9 cases in a given community, and the blue outlines around certain communities really represent communities in which there was a case in the more recent epidemiologic week, that is week 3, whereas there was none in that community in the epidemiologic week before, that being epidemiologic week 2. We also look at the Tobago to the inset. It's placed in the Gulf of Paria only for convenience and representation, and we have continuing low numbers of cases in those communities at this point in time. So again, while we see this and we may highlight the higher levels of activity in specific places, we don't want the population to come away with the impression or the perception that it's only in these places that we're seeing COVID and therefore everyone else is free to do as before. We do want to emphasize that the reason we're seeing these numbers being as low as they are is because we're having greater levels of general adherence. I think people are falling into the habit now of what we call the new normal, and we need to have that continue. We need to ensure that individuals understand that each individual decision that you make with regard to going out into gatherings, not wearing masks, etc., those things affect your probability of A, becoming infected, or B, possibly infecting someone else. So again, we send out the call to all persons: avoid gatherings, avoid going to work or into workplaces with any sort of respiratory or flu-like symptoms. We are still seeing where people feel compelled to go to work, go into the workplace, although they weren't feeling so well, and we see where clusters arise around that kind of behavior. So we do want to emphasize that any sort of flu-like illness should prompt you to withdraw your physical presence from work. If you can work remotely, then this is an option. Please take it, and we reduce the risk of putting ill people with respiratory symptoms into indoor environments where the possibility of infecting other workmates could happen. So physical distancing, the hand hygiene, the mask wearing, the not gathering, and not going to work when you're ill are the main messages that, again, we want to reiterate, so we can see if we can keep these numbers at the low level they currently are. And again, just remembering that as we move into our other festive season in its absence, we don't want to have replacement gatherings. We want to keep the risk as low as possible. So with that, I'll turn you back to CMO.
Okay, thank you very much, Dr. Hines. We now go to Dr. Mohammed to provide us some insight into the phenomenon we have explored, which is long COVID. I know she would have given a similar presentation some months ago. And of course, we would have learned a lot by way of research, by way of seeing patients in our setting, as well as internationally over those months. So Dr. Mohammed, please go into your presentation.
Good morning. Thank you, Dr. Parasram, Chief Medical Officer, Dr. Avery Hines, Technical Director in the Epidemiology Division, Ministry of Health, members of the media, and members of the listening and viewing public. So today I have the pleasure of speaking about long COVID, which is an important aspect of COVID-19. When we think about COVID-19, there's a widespread perception that patients either make a full recovery, get admitted to hospital, or some may die. But it's become increasingly clear that for some patients, there are ongoing effects of COVID-19. Patients, their families, healthcare professions, and the population as a whole need realistic expectations about what may happen next. So what exactly is long COVID? Well, long COVID refers to the signs and symptoms that occur during COVID-19 infection or following COVID-19 infection that persist for more than 4 weeks and are not explained by another medical condition. Symptoms of long COVID are very variable. May I ask for my first slide? So the most reported symptoms of long COVID are fatigue, profound fatigue, and shortness of breath. And I want to stress on the word profound, as our patients describe this fatigue as unlike anything they've ever experienced before. As can be seen on the slide, patients complain of many symptoms from a wide range of body systems at different times and of varying severity. In fact, every single body system can be involved. Many patients describe a waxing and waning nature of the illness, where you feel as though 1 minute you've recovered, but then it hits you back. One patient described this as, it's a constant cycle of disappointment, not just to you, but to those around you who really want you to recover. May I have my second slide? So this is a cartoon on long COVID, and it clearly depicts this feeling. The first character says, why is it just me? And patients may at times feel isolated and that they are the only ones experiencing ongoing symptoms following COVID-19 infection. But as they go along on their journey, it becomes more evident that there are other patients experiencing the same symptoms. And then they feel, oh, there are loads of people like this. But as the data grows, we will be able to identify at-risk groups of patients. May I have my third slide? So this study was taken in more than 4,000 COVID patients in 3 different countries. And I must stress that this this study has not yet been peer-reviewed, but it's a large body of data that has shown some trends. So who is affected by long COVID? Well, reporting more than any 5 symptoms in the first week of onset increases your chances of long COVID. Symptoms lasting more than 28 days occurred in 13.3% of the patients. And what's important is that in 2.3%, symptoms persisted for more than 3 months following infection with COVID-19. With regards to age, increasing age and the elderly population were certainly more at risk of long COVID. But if we look at the 18 to 49-year-olds, the young patients, there is still a significant amount of patients, about 10%, who experience long COVID. Women were more susceptible than men, but this did not hold true for older age groups. Long COVID certainly affected all socioeconomic groups. Asthma was the only pre-existing condition which was associated with long COVID, and individuals with long COVID were more likely to have required hospital assessment. So what is important for us to note is that cases of long COVID can occur in young, previously well individuals who were not admitted to hospital. The common perception that COVID-19 is an old person disease is unrealistic, and young persons can certainly go on to experience long COVID. So aside from the numerous health consequences of long COVID, there are also psychological, social, financial, and economic burden on some of our patients. Some patients may be unable to work and have much difficulty returning to work following infection with COVID-19. Some of our patients have difficulty returning to their normal day-to-day function following infection. Complications following infection with viruses are not new. We should all remember the Zika virus, which has been known to cause neurological complications that has been reported by our local health authorities. Locally, we've had a chikungunya, and in some cases, joint pain was reported to persist for several months or even years after infection. And many of us personally know persons who have had persistent joint pain following CHIKV infection. So the concept of long-term symptoms or complications of viral infections should be widely accepted. And although COVID-19 is caused by coronavirus, which is a different virus, it is important for us to acknowledge the long-term health consequences of COVID-19 infection. And this is especially important for those of us who believe that if we get COVID-19, we will simply recover and that our chances of dying is low, especially for those who are young with no pre-existing medical conditions. And although this may be true, I want to emphasize that even in this group, it is certainly possible to experience long COVID and long-term health consequences of COVID-19 infection. So in managing long COVID, patients benefit from a holistic approach. Education is key to both patients and healthcare professionals looking after these patients about what services are available for assessment and management of this often challenging group of patients. Currently, nationally, there are 2 centers, both called the Executive Wellness Center, located at the Arima General Hospital and at the Couva Medical and Multi-Training Facility within the North Central Regional Health Authority, that have both been conceptualized to look after our patients who have recovered from COVID-19, some of whom have long COVID. These both clinics are specialist clinics and use a multidisciplinary team approach, which is the standard of care for management of these patients. So given the multitude of symptoms of long COVID and the long-term health consequences of COVID-19 infection, it is likely that large numbers of patients will experience complications of COVID-19. This will have a significant impact on our healthcare systems for years to come. So it's extremely important for us, the population, to follow all the public health guidelines constantly advised by the Ministry of Health. And these include mandatory mask wearing, avoiding gathering, social distancing, staying at home if you are ill, and hand washing. It is also important for you to be responsible and to encourage your family and your friends to do the same. The only way to prevent long COVID is to prevent COVID-19 infection. And remember that we are all in this together. I thank you for your attentiveness.
Thank you very much, Dr. Mohammed, for the reminder of all the things that we need to do as members of the public to help protect ourselves and our loved ones. And we go, as you know, every Wednesday, we go into questions that are sent to us from members of the public. And so we start with the first question: does my cancer treatment put me at a higher risk of getting COVID-19? Dr. Hines, this one is off to you.
Okay, thanks for the question. Now, the cancer treatment doesn't put you at a higher risk of contracting the virus itself, but because some cancer treatments are immunosuppressive in nature, they suppress the immune system's ability to respond, it can put you at a higher risk of having more severe disease if you do actually contract the virus. So this is a good example of where priming the immune system beforehand via vaccination puts you at an advantage. So you don't have the same risk of severe disease because your immune system already knows how to respond, having been primed by the vaccination process. So while the treatment doesn't put you at higher risk of getting COVID, the treatment may put you at higher risk of the more severe complications, and definitely would be one of the good reasons to consider getting vaccinated.
Thank you very much, Dr. Hines. And second question that has come into us from the public: will a COVID-19 vaccination protect me from getting sick with COVID-19? CMO, I think this one is for you.
Yes, so having a vaccine, the point of having a vaccine is to produce antibodies which present themselves in your body thereafter, 2 to 3 weeks thereafter vaccination. And what it does, it supposed to prevent disease. What happens, for example, let's use the Pfizer vaccine, which purports to be 95% effective. So it means that if 100 persons are vaccinated with that particular vaccine, 95% of those will not manifest disease. 5%, however, will actually manifest some disease. So what we have seen with the research and with vaccination programs, although that 5% may actually get COVID, COVID will not be as severe as if you had not been vaccinated. So there's a small proportion, and that's where we determine the vaccine efficacy of persons who actually have vaccines will get the disease, but generally speaking, they are milder in nature and lack the complications that you see when you are unvaccinated. So vaccines are another way to protect yourself from the complications of COVID-19 or any other vaccine-preventable disease.
Thank you, CMO. Very interesting clarification point there. And this third question, I think Dr. Mohammed will take because it links directly to her presentation. Is long COVID contagious?
So no, long COVID is not usually contagious. But long COVID symptoms are caused by the body's response to the initial COVID-19 infection. And this occurs even after the virus is inactive. So long COVID is not usually contagious. So unless you have reinfection, long COVID should not be contagious. But what's important for us to realize is that COVID is contagious and reinfection is certainly possible and has occurred before. So it's very, very important that even though long COVID is not contagious, those persons experiencing long COVID symptoms should still go on to adhere to the public health guidelines, continuously being advised by the Ministry of Health.
Very much, Dr. Mohammed. And we go now to our question and answer segment. Members of the media, please begin by stating your name and the name of the media house that you represent. We ask for 2 brief questions, please. Of course, as you know, we will come back to you if we have additional time. And we go now to AZP News, please.
Hi, good morning. Prabhi Hari, azpnews.com. My first question, I think the CMO may be able to answer this. There were reports that the African Union is offering our region some COVID vaccines by Pfizer. Are there any plans for us to accept those? That's my first question. And my second question has to do with, there are reports again that poorer countries are paying more for the vaccines via COVAX than the price that the, the European countries pay for it. Is there anything in place to ensure that we don't pay, more than what is being paid in other countries for these vaccines? Thank you.
Okay. All right. So as the Honourable Minister would have indicated yesterday in his response to the question as it relates to vaccines, Trinidad and Tobago are exploring three broad areas to get the vaccine. So the broad areas are, again, the COVAX facility. The other area we are looking at is bilateral talks with the vaccine manufacturers, which, as we stated before, has begun since October 1st with various countries. And the last area of collaboration is through a CARICOM initiative, which is looking at vaccine consolidation in the region. So those are the three areas that we are looking at this point. I don't want to go into any further details until we sign, because we sign certain confidentiality agreements with vaccine manufacturers. So we can't divulge too much of the information until all of those legal hurdles are crossed. With regards to the pricing scheme, the Pan American Health Organization is responsible for ensuring that there's equitable distribution, equity in terms of price, and equity in terms of supply. So that matter will really lie with the PAHO WHO organizations, not with individual countries, to see what is being paid by different member states. So that matter is to be dealt with by WHO PAHO level, at that level.
Thank you very much, CMO. We go now to TV6, please.
Hi, good morning. Alicia Boucher from TV6. My first question is to Dr. Parasram. Dr. Parasram, based on the components of the other vaccines, are there any other vaccines that persons with those allergic reactions that you would have mentioned, such as seafood reactions, allergic reactions to medication, that they can take from the set that we are considering the other three? And the second question is to Dr. Hines. Dr. Hines, do we have any data at this point, based on percentage or otherwise, to say how much these DESA parties are contributing to the active cases within the active COVID-19 cases within the population? Thank you.
Okay, so the first question is a very good question. So generally speaking, when you have, let us use the analogy, we have different types of pain medication, for example. So a patient might be allergic to one particular type of medication. They may be allergic to aspirin, for example, and we decide to use another type of medication in those particular individuals. So what I mentioned earlier, it is the WHO SAGE group's pronouncement on Pfizer vaccine in particular, and that issue with persons having severe allergies is specific to that particular vaccine. Now, if other vaccines, for example, the AstraZeneca vaccine or any of the other vaccines that we may eventually get in Trinidad and Tobago, has a side effect profile that is somewhat different and allows for persons or is not as immunogenic, it doesn't have that immunogenicity that is being said of the Pfizer, then of course we can offer it as an alternative for persons in that group. But that will only come forth once there has been approval by WHO, one. So as you know, the only vaccine that has been approved by the COVAX facility by WHO for emergency use within the COVAX for now is the Pfizer vaccine. But again, as they approve other vaccines into that facility, they will do similar recommendations to the SAGE group again, so that we will know what the side effect profile is, and then of course we will base our national tags consideration on those findings. So, but it is definitely an option that we may have in the coming months. Dr. Hines.
Dr. Hines, the next question.
Okay, thank you for the question. Now, again, the challenge in pegging any one particular event to the cases that arise subsequently is dependent on the individuals who then test positive and are asked about their contacts, their whereabouts, their behaviors, actually identifying participation in said event. So while that seldom, if ever, actually does happen, occasionally you do find individuals that will say, I went to this event, to that one. But that wouldn't then constitute enough data to say this party or that party then contributed to the numbers of cases that we're seeing. But what we can say across the board at a general population level is that the more of these events we have, the more there is a tendency to have these events underground, behind the scenes, the greater the numbers of cases we will see in the population, as we've seen in the past. Any congregational type event over a protracted period of time, over several different types of events, those then accumulate in the population to provide those larger numbers that we see as an upward trend subsequent to those behaviors being demonstrated. So while we can't peg it directly, we do know that the behaviors themselves have repeatedly, recurringly been noted to then result in an overall increase in numbers of cases in diagnosed on a day-to-day basis.
Thank you very much, Dr. Hines. And we go now to TTT, please.
Hi, good morning. Sonal Lala from TTT News. Dr. Parashram, I know you would have spoken about allergies with regards to the vaccine. Does it say anything about persons with high sensitivity to food? Can they take the vaccine? What is the recommendations for that? And secondly, for Dr. Hines, we've just come off a high election season in Tobago. I know Dr. Tiffany Hoyt would have already expressed concern over the lack of adherence to some COVID-19 guidelines, especially over the weekend and late last week. How is the ministry concerned about a possible increase in cases in Tobago? I know Tobago doesn't have as much cases right now, but how are you moving forward in terms of that? Is there anything to increase testing in Tobago? How is the ministry collaborating with Tobago to see about this?
Okay, so your first question, high sensitivity to food, as we said, so the recommendation is very broad. Persons who have had severe allergic reactions of any type, including to food, for example, seafood is the most common type of allergy you tend to get. If you have allergies to bee stings, for example, you would be included in someone that would have had severe allergies prior, and then, of course, you should not have the vaccine at this point. So, yes, to food, if you have had severe allergies, then you should not get this particular vaccine at this point. Dr. Hines?
Okay, thank you for the question. Again, the issue of gatherings and the behavior that is currently being advocated against, that behavior manifesting itself at various points in time, is, of course, a cause for concern for the ministry. We echo Dr. Hoyt's concerns in terms of monitoring, the ongoing monitoring of the population to see how any gatherings that would have taken place over the past couple of weeks would reflect in changes in the cases going forward. So we do have that surveillance that is ongoing. The ministry collaborates with the CMOH office in Tobago to look at the changes in number of cases. The testing is ongoing, and anybody with flu-like symptoms, of course, is encouraged to come forward to be tested so that the appropriate isolation and contact tracing can take place. What's important to note is that in advance of any potential increases, if the first group of people who become ill, if they present, if they identify contacts, if they isolate, then we can actually take proactive steps to blunt any increase, and that's probably the most important message. If, as the weeks go by, we are starting to see more cases of flu-like illness, we do want to ensure that people are encouraged to come forward for testing so that the appropriate contact tracing and isolation can be done so that we can reduce the risk of having a large increase. We will continue to monitor and we'll continue to keep the population apprised as appropriate.
Thank you. And we go to Wired 868 now, please.
Hi, good morning. This is Fayola Bostic from Wired 868. My first question has to do with the availability of the vaccines. We know that currently the EU is in a kind of quarrel with vaccine manufacturers who are saying that they're not able to produce enough vaccines to meet their contractual obligations. So I'm wondering, how nervous are we that we won't be able to get extra vaccines outside of the COVAX facility? So that's the first question. My second question has to do with persons who are experiencing long COVID. How can they differentiate whether or not they're having another episode or if they have been reinfected and are now contagious?
Okay, so I think your first question is how nervous are we? I think generally the reason we are exploring multiple options, whenever you have a vaccine that is in such high demand, and of course production is a challenge and will be a challenge going forward because of the demand. So that's hence the reason we are exploring 3 different options at this point in time. Most of the manufacturers would have committed supplies to COVAX prior to going to external markets, so at least we have that confidence that through the COVAX facility, the supplies will be guaranteed based on the arrangements with COVAX at some point. But again, we continue to explore all options to ensure that we have multiple tracks to procure vaccines, so that if there's an issue with one particular track, we have some other procurement mechanisms to fall back onto.
Okay, thank you, CMO. And the second question, we'll send it to Dr. Mohammed, please. And so the question asks to differentiate between a reinfection and long COVID. So I think Dr. Mohammed would be the best person to respond.
Okay. So thank you very much for this question. This is a very, very good question, and it's quite difficult at times to differentiate between ongoing symptoms of long COVID and new symptoms of reinfection following COVID-19 infection. Some of the symptoms might overlap. We've seen on the slides that there are a wide range of symptoms. Some of these symptoms can represent long COVID, and some might represent new infection or reinfection with COVID-19. So it's very, very difficult at times to differentiate. The best advice that I would give is that for those of us who have had COVID-19 before and are still experiencing ongoing symptoms or new symptoms, the best advice is to seek medical attention. Some of these patients will require retesting for clarification of symptoms. It is always important for those patients who have recovered from COVID-19 to continue to adhere to the public health guidelines, therefore decreasing their chance of becoming reinfected with COVID-19. That would be the most important message.
Thank you very much, Dr. Mohammed. We go now to a follow-up question from TV6, please.
Hi, this question is for Dr. Mohammed. Dr. Mohammed, do we have a mortality rate as it relates to long COVID, and do we know the prevalence of it in our population?
Dr. Mohammed, we go straight to Dr. Mohammed. Thank you.
Okay. So with regards to the prevalence of it in our population, I think we're in the process of collecting the data since we're still quite early in the pandemic, and the evidence for long COVID has been becoming increasingly more sufficient in recent times. With regards to the mortality rate, I'm not aware of a figure that I can quote for you for the mortality rate of long COVID.
Okay, thank you very much, Dr. Mohammed. Follow-up question now from TTT, please.
Hi, good morning again. Sonal Lala, TTT News. CMO, I know the minister would have made an announcement that with regards to the COVID-19 vaccine, the quantities and so on. In preparation for that, any updates on the chillers which were to be installed at the Couva multi-training facility? I know tender submissions would have been submitted at the end of last year, early this year. Where are we with that? I know it was supposed to be installed by February. Are we still on track with that?
Yeah, so I can say that the tenders have actually been closed and the contract has been awarded. That matter is being dealt with by the North Central Regional Health Authority in terms of the timeline and all of that. That will be closely looked at by the team at the North Central Regional Health Authority to assure that we do get what was in the tender delivered in a timely fashion.
Okay, thank you, CMO. I just wanted to raise, CMO, there's a question following up on one of the questions we addressed today from the media. There's a question we're getting about severe allergic reactions, and what is the difference between a severe allergic reaction and a mild allergic reaction?
Okay, so it is something, a mild allergic reaction we would have seen, for example, if you touch a plant and you get a localized reaction, maybe a rash in one particular part of your body that is common, you tend to get into the severe spectrum when you have difficulty breathing, you have swelling of your tongue, your lips, that sort of thing, and you require emergency management. So if you have a severe allergic reaction, all of body rash, that sort of thing, you usually have to seek treatment at a facility at that point in time. So it should be documented, or it should be an event that you can recall if it happened before. It should be a very significant event in terms of your medical history. See, mild allergies, again, happen from time to time, most commonly from the use of products that are applied to your skin. Once you start to get allergies from foods, for example, seafood, and antibiotics, those tend to lean more towards the severe form of allergic reactions.
Great. Thank you very much, CMO. Dr. Mohammed, as well, you mentioned the 2 locations where patients who have long COVID are being treated. Could you tell us some of the services that are being offered to patients who present with long COVID? I know you mentioned Arima and I think Kuva.
So both clinics fall within the realms of the North Central Regional Health Authority. And the service is a service which is patient-oriented, and it was conceptualized specifically to meet the needs of this challenging group of patients. So patients are managed by a holistic approach. So it's a one-day event, and they come in. They have bloods done, ECGs, chest x-rays, or whatever investigations that are required for their follow-up. They go on to meet a multidisciplinary team of healthcare professionals, including physiotherapists, medical social workers, dietitians, specialists, including endocrinologists, nephrologists, cardiologists, pulmonologists, to name a few. And patients essentially have whichever specialist review that they require. So for example, if someone has ongoing shortness of breath, they may have lung function test, x-ray, and have review by pulmonologists. If someone has ongoing chest pain, they may have an echocardiogram and review by a cardiologist. So it's a very specialized clinic designed to meet the needs of this growing population and this at times challenging group of patients.
Thank you very much, Dr. Mohammed. I think Wired 868, we have another question from you.
Okay, so a quick follow-up question. This has to do with the vaccines and some vaccine skepticism that we've been seeing in the population. I think it was one of the dailies ran a letter to the editor, I believe. So people are asking if you can still be infected with COVID after taking the vaccine, and if you can still transmit it, then what are the benefits really? And also the case fatality rate is low, and so many people don't have any symptoms at all. What is the benefit of being vaccinated?
Okay, so again, the benefit of vaccination, we can't look at Trinidad and Tobago alone in isolation. Our numbers seem to be low for now. Let us cast our mind back to August and September, when we had deaths occurring in this country on a daily basis, sometimes more than one on a daily basis. And we have seen a little bit of the tip of the iceberg as to what COVID-19 can do, and very quickly filled our hospitals at Kuva and at Kora over the space of a couple of weeks. We have countries around the world that don't have that capacity anymore. They don't have hospital capacity. They don't have ICU capacity. Continuing the public health measures, vaccination is another tier of our public health armory that we add to it to improve, and hopefully our first phase is to protect the vulnerable in terms of vaccination. Our second phase will be going towards herd immunity, ensuring that a significant proportion of the population is vaccinated to allow for a decreased transmission of the virus in the country. And I think that's what the world is trying to do as well. For example, a country like India has a milestone of looking at 300 million vaccines to be given by the middle of the year. So we are all looking in that direction. Vaccination is a public health tool, but even at a personal level, it prevents disease. In the case of Pfizer, up to 95% of persons who actually get the vaccine won't get disease. And as we have seen, if you belong to that vulnerable population, your risk of death is increasing with increasing age. So we would like to protect those people first with our vaccines, and that's the strategy that we are using in Trinidad and Tobago. And just to give you an idea, I know Minister would have been on Friday last and would have indicated that by the time he comes on next, the number of worldwide cases would have surpassed 100 million. So today, the worldwide cases now stand at 100,989,348, 2,171,000 deaths, 104, giving us a total current active caseload of 25, upwards of 25 million people. And in terms of proportion, those cases per day, there seems to be continued rise in the number of cases, over 500,000 cases per day. And again, our death rate in the world is over 15,000 deaths per day. So in terms of the epidemic not slowing down, it is really not slowing down in terms of proportion. The only public health measure we have in terms of interrupting that transmission, and that's why the world has put so much emphasis on vaccination, is actually getting a safe, effective vaccine delivered to the majority of the population of the world.
Thank you very much, CMO, for that reality check. We always appreciate questions that come from the public, the opportunity to provide accurate information and to address any myths that are in the population. And our final question this morning from TV6, please.
Hi, my question is for Dr. Mohammed again. Do we know at this time why persons with asthma seem more susceptible to long COVID, and is there a medication regime to treat the symptoms of long COVID?
So we don't at this time know why patients with asthma seem more susceptible to developing long COVID. Just remember, the data provided was from one study, and as we go along through the pandemic, more and more concrete data from different countries and different populations will become available to us. So it might be that we recognize that there are other conditions that can put patients at risk for long COVID, but at this time, from the study represented on the slide, asthma seems to be the only medical condition that predisposes to long COVID. So we don't actually know why. It may be that asthma is a respiratory condition and that it can be exacerbated by COVID, but there's no concrete data to suggest why. With regards to the second part of the question, if there's a medication to treat long COVID, no, there's no one medication to treat long COVID. These patients are very complex and they are at times challenging, and they require a multidisciplinary team approach and a holistic approach really to manage these patients depending on their specific body symptoms and systems involved.
Thank you very much, Dr. Mohammed. And we have come to the end of this morning's media conference. Thank you everyone for joining us. And before we go to the WHO video on vaccines and variants, I just ask that we all reflect on the numerous loved ones that have been lost and also cast our minds on the lives that can be saved if we all do our part. It's simple. Please stay home if you don't need to go outside. And of course, wear your mask the right way every time. Do have a good day and be safe.
We're hearing about variants of the SARS-CoV-2 virus that causes COVID-19. How concerned should we be, and do vaccines provide protection against these variants? Welcome to Science in 5. I'm Vismita Gupta-Smith, and this is WHO's Conversations in Science. Answering these questions today will be WHO's Chief Scientist, Dr. Soumya Swaminathan. Welcome, Soumya.
Hello, Vismita. Nice to be back with you again on Science in 5.
Soumya, tell us what we know about these variants. How concerned should we be, and is it unusual for viruses to change?
From the beginning of the year, we've been tracking this virus, and we know that it's gone through a lot of changes, and there have been variants before. Now, this particular time, there have been two particular variants that have been reported